Right. Patanga Babene. Right. Okay. Right. Right. Okay, so now we are going to spend a few days on short cases because we finished off all the long cases. So I want to spend a few days. I'm not going to do all the systems, but I thought we'd start with neurology because that's what most people find it difficult. And then we'll probably do neurology for about 2 days, I think. Yeah. And then that'll be today and Monday. And then I will also do cardiovascular, and then we need to do the emergencies. So we should have enough time. And depending on when your OSCE is, we can do it either the OSCE class on Monday or Wednesday, depending on when your OSCE is. Right? So we should be finished in time for, I think, emergency medicine. We will finish off next week. Yeah. Right. We should be done. Okay. Right. So now, in general, short cases are very important because they can help you to score marks. Okay. Because the problem with the long cases, it's rather examiner dependent. එතකොට දැන් උදාහරණයක් වශයෙන් දැන් අපි නම් කියන්නේ හැමෝම දැන් because I'm also part of the department now, but essentially some people කොච්චර හොඳට කරත් 60යි දෙන්නේ, right? However well you do, only 60 marks හැමදාම දෙන්නේ, right? Whereas some people score you high or lower depending on what you do. But short case is far more objective and easy to score. So if you have got everything right, you will get the full marks even. Okay, so that's important. Hari. Now, as you know, you have 4 short cases. Hari. One from each system. Hari. Everybody knows that. And you will have about 7.5 minutes per short case, right? And this from this 7.5 minutes, 5 minutes will be for examination, and then 2.5 minutes for discussion. And remember, in the 2.5 minutes, you are supposed to present your findings as well as discuss a few things about the differential diagnosis and some physical science related questions. Okay, so that's how you use that time, 2.5 minutes. So that goes very, very quickly. So sometimes it's very difficult. Now, in order to do the short case well, your examination technique should come at a brainstem level. That's very important. So the next few months of leading up to your exam, you should focus a lot on getting your examination technique without thinking. Right? That is very important. Because you have to do it very quickly. Your whole brain power should focus on the physical science, not the technique. So practice the technique so that they become a reflex to you, right? That you do it without even thinking what to do next. So that is very important to succeed at the short case. Right? So technique should be absolutely perfect and come at a reflex level. Very important. The second thing to do well in the examination technique is the short case examination is to examine as many patients as you can, right? And think about physical science and how you would talk about these physical science and interpret these physical science. Right? Remember, we won't ask a lot about management in the short case discussion. It will be mainly focused on the diagnosis, differential diagnosis, how to interpret the physical science that you've detected. Right? Very rarely, we will ask you questions about management. Very, very rarely. Right? So don't worry too much. We'll just focus on the diagnosis and differential diagnosis most of the time. Right. Okay. Now, neurology, the short cases can be either cranial nerve examination, okay, or it can be a limb examination. Okay, so you, depending on the case you get, it might be a cranial nerve exam or a limb exam. So today, let's focus on the cranial nerve examination. Right? Now, in the cranial nerve examination, there are several types of commands that you can get. So listen carefully to the command. The first sort of command you might get is examine the motor cranial nerves. That's a common instruction. Examine the motor cranial nerves. What that means is all the cranial nerves that have a motor component or a motor innervation should be examined. right? So even things like the pupillary reflex should be examined because that's a motor component of a cranial nerve. Right? So practice it in that way, motor cranial nerves. We can also ask you to examine the upper cranial nerves. So upper cranial nerves can be 1 to 6. One we usually don't worry about too much. 1 to 6. That is upper cranial nerves. Another command, especially when you're focusing on sort of palatal problems, etc., would be lower cranial nerves. Examine the lower cranial nerves. That is another command. So that is 7 to 12. 7 to 12. And most often the problem is either facial nerve or somewhere in the palate. Okay, or tongue. Okay. Sometimes this is not a common instruction, but we might ask you to examine the eyes neurologically. Eyes neurologically. So that's visual acuity, visual fields, eye movements, pupillary reflexes, and so on. So that is examine the eyes neurologically. So these are the 4 types of commands that you can get when you're doing a cranial nerve examination. Right? So practice it in all those ways. So when you usually when you go to see cases, and I'm sure you're going to do that or you're already doing this, you have to go with a friend. Either 1 or 2 of your friends or colleagues, you go there and practice all of these ways, right? And one person can give feedback. Okay, that's how it goes. Of course, it is good to present if possible to a registrar or somebody or HO or SR. And if you're bold enough to a consultant, and many of the consultants are sometimes happy to do that for you. Right? And in these classes also, they would have done this already. Right? Okay. All right, so let's talk about this. So I've just organized this in a case-based format so that we can sort of discuss. So the first case is, say, examining the eyes neurologically. You found the deficiency or the problem in the visual fields. Okay, and the disease is or the clinical sign is a left homonymous hemianopia. And obviously, at the exam, we will only ask you 2 questions in neurology. So the 2 questions are, where is the lesion and what is the lesion? Short case, those are the 2 questions that we will ask you. So similarly, in this case, let's ask ourselves the question, where is the lesion first? Where is the lesion? Okay. So if you got this case, then okay, you obviously need to know this this diagram or figure to make the diagnosis of where the lesion is. Okay, so this is the optic pathway and lesions at various places. Right? So from this figure, there are only 2 important places that you should worry about. Okay, as an undergraduate. The first important place is B. Okay, a lesion at the optic chiasma. Okay, and as you know, a lesion at the optic chiasma will give you bitemporal hemianopia. Right, bitemporal hemianopia. So that is one place that we are worried about. The other important, so one possible short case might be a case of bitemporal hemianopia. And you know the lesion is then in the optic chiasma. Right. Another physical sign that you might get, like in this case that I have just given you, case number 1, is the homonymous hemianopia. Homonymous hemianopia. Now, the moment you find a homonymous hemianopia, that means that the lesion could be any point beyond the optic chiasma. So anything behind or beyond the optic chiasma, lesion in the optic tract, optic radiation, or occipital cortex can give rise to a homonymous hemianopia. Homonymous hemianopia. So optic tract, radiation, or occipital cortex can give rise to homonymous hemianopia. Okay. A little note when the lesion is in the optic radiation, that is D, you usually get either an upper or a lower homonymous sort of, it's a quadrantanopia, right? So make a note of that. When it's in the optic radiation, either it's just the upper or lower part. And the reason is because the optic radiation spreads through the parietal lobe and the temporal lobe. It spreads through a massive area, it's not a single bunch of fibers. So you have the optic tract, which is a single bunch of fibers, then it radiates. Part of it goes to the parietal lobe, part of it goes to the occipit, the temporal lobe, and reaches the occipital lobe, right? So optic radiation disease is usually upper or lower quadrantanopias. Just make a note of that. All right. Fine. So when you have homonymous hemianopia, the lesion is distal to the optic chiasm. That is what you should know, right? Hurry. Now then, if you think of common things first, okay, and at the undergraduate exam, you will say that homonymous hemianopia is a lesion, so beyond the optic chiasma, that is quite clear. The lesion is often in the occipital cortex. Okay, so when you have homonymous hemianopia, especially when there's a complete defect, not an upper or lower, complete defect, the lesion is often in the occipital cortex. Occipital cortex. So ඒකත් අපි අන්තිමට කිව්වට කමක් නැහැ. හරි. Common things, occipital cortex. There are actually clinically, you can say, track the radiation, the cortex. There are some other physical signs, but those are not important for you as an undergraduate. The only thing we will expect of you, if you get a homonymous hemianopia, is to say that the lesion will be beyond the optic chiasma කියන එක, right? And say commonly in the occipital cortex when there is a complete homonymous hemianopia, right? And you know the reason for that, because in the optic radiation, you have this fiber spreading over a large area. That will be the parietal lobe and the temporal lobe. Okay. Any questions? So, right. Now, then somebody might also ask you, right, fine, now what is the etiology? What is the etiology? Now, focusing on the occipital lobe, which is the commonest site of lesion in a homonymous hemianopia, there are two pathologies which are possible. One, and write this down very carefully, one is an infarct of the occipital cortex. Infarct of the occipital cortex. The second etiology is a tumor or a space-occupying lesion in the occipital cortex. So these are the two etiologies that we see in the occipital cortex, right? And clinically, you can actually differentiate whether it's a tumor or an infarct, right? That is important, and that is a question that we like to ask you also. So if you get a case of homonymous hemianopia, we will ask you about how to differentiate whether it's an infarct or a space-occupying lesion. Now, the fundamental difference, the main difference or the fundamental difference between an infarct and a tumor is that an infarct will always follow a vascular territory. Infarct will always be a vascular territory. And we know that the occipital cortical infarct is due to a posterior cerebral artery disease. Posterior cerebral artery disease. We know that. Right? Whereas a tumor will not have a vascular orientation, because it infiltrates everywhere in the occipital cortex. It does not have a vascular orientation. So two common causes of occipital lobe disease causing homonymous hemianopia. Number one, infarct. Number two, tumor. And we can, using physical science, differentiate this. The basic overlying principle here is that infarct always has a vascular territory orientation, whereas a tumor does not have a vascular territory orientation. That is clear. Okay. Right. So the vascular territory orientation is the occipital lobe, is the posterior cerebral artery supplied to the occipital lobe. Right. Okay. Right. Now, the very important thing about the posterior cerebral artery supplied to the occipital lobe is, right, it supplies all the occipital cortex except the area representing the macula. Okay. It supplies the whole of the occipital cortex vision area except for the part that supplies the macula. So if there is a posterior cerebral artery infarct, it will cause a homonymous hemianopia, but the macular region will be spared, and that is what you call macular sparing. Okay, macular sparing. So in other words, you will get macular sparing when it's an infarct of the occipital lobe. So you get homonymous hemianopia with macular sparing, And at the exam, again, I will explain what is the basis of macular sparing. Right? The basis of macular sparing is the macular area is not supplied by the posterior cerebral artery, which is actually supplied by a branch of the middle cerebral artery. Okay, it is actually supplied predominantly by a branch of the middle cerebral artery. Okay, So therefore, if you get a posterior cerebral artery infarct, you get an occipital infarct with homonymous amblyopia, but there is macular sparing because remember the macula is supplied by the middle cerebral artery. So that is the reason for that. Hi, okay. So these are the common questions that can be asked from this sort of case. Okay. So where is the lesion cause? We have given two causes, and then we might ask you what is macular sparing and how it is useful. And I hope that now you will be able to answer all these three questions. Right? Any problems there? And please ask one of your SRs or registrars to show you how to look for macular sparing, right? Because we might ask you to demonstrate that in the short case. Right? Macular sparing balana vidya kohomada kiyala igana ganna. Please ask somebody. Okay. Now, if you get a bitemporal hemianopia, for instance, the etiology there is, what is the etiology there? Bitemporal hemianopia, chiasmal lesion. The etiology is often a pituitary disease, a tumor most often. Okay, tumor. And sometimes, if we are able to find, we might give you, say, for example, a patient with Cushing's or acromegaly with a bitemporal hemianopia. Showcase. Then you can make the diagnosis by just by looking at the patient. So, you say bitemporal hemianopia, you can see the acromegaly or Cushing's features and make sure that there is a pituitary tumor pressing on the optic chiasm. Okay, so ඒ වගේ හොඳ short cases සමහර වෙලාවට දෙන්න පුළුවන්. Neurosurgery patients ලගේ සමහරලාට ඒ වගේ හොයා ගන්න පුළුවන්. හරි. Any questions from case number 1? අහන්න ළමයි මොකද මේක ආයි මට වෙලා තියෙන එකක් නැහැ ඔයගොල්ලන්ට කරන්න විභාගයට යන්න කලින්. So please ask any question. I know that neurology is difficult for most of you. That's why I want to finish that first. Okay, fine. So case number 2, from the picture, you can see that the patient has bilateral ptosis. Okay, bilateral ptosis. So let's talk about ptosis then. Right? So the case here is ptosis. And again, let's try to answer the question, where is the lesion first? Okay, right. All right. Now, what is ptosis due to? In order to answer the question, where is the lesion, you should understand what is ptosis. What is the basis of ptosis, reason for ptosis? The reason for ptosis is weakness of the levator palpebrae superioris muscle. That is the cause of ptosis is the weakness of the levator palpebrae superioris muscle. Now, the levator palpebrae superioris muscle, as you know, has two components. First component, it has a skeletal muscle component, which is innervated by the third nerve. Okay. And also smaller smooth muscle component, which is innervated by the sympathetic plexus. Okay. So that is the sort of anatomy of the levator palpebrae superioris muscle. So weakness of the levator palpebrae superioris will give you ptosis. Now, when you approach ptosis, the easy way to approach, you see a patient with ptosis at your short case, the easy way to approach this is, see, is it bilateral or unilateral? Okay, is it bilateral or unilateral? If it's unilateral, then the lesion is either a third nerve related problem, okay, third nerve related problem, or it might be a Horner's syndrome. So as you know, Horner's syndrome is sympathetic nervous system problem. And with the ptosis, which is partial ptosis in Horner's syndrome, we will also have pupillary constriction, right, and absent sweating on that side of the face. Right, so especially around the eye and the forehead. So there are other features in Horner's syndrome, and we can find a patient with Horner's syndrome for your short case, right? So they get partial ptosis, small pupil, and lack of sweating, right? So if it's unilateral ptosis, easy problem, game, no problem, third nerve or related issue or Horner's syndrome. So in that sense, you will have to discuss that. I'll talk about third nerve palsy in case number 3. But here we have a patient with bilateral ptosis. In this picture, we have bilateral ptosis. So what is the localization of bilateral ptosis? So if you start in the muscle level, right, bilateral ptosis can be due to myopathy. There are special types of myopathies called ocular myopathy. And also there is a disease called myotonia dystrophica, which I'm sure Professor Chang would have shown you some videos about. myotonia dystrophica, right? So these are all muscle disease that cause bilateral ptosis. And myotonia dystrophica has some special physical signs also in the rare case. But bilateral ptosis can be due to muscle disease. And remember, in muscle disease, as we have discussed before, the ptosis will be bilateral symmetrical ptosis usually, right? Bilateral symmetrical ptosis. Okay. And there may be eye movement abnormalities also. So the extraocular muscles also may be involved due to the muscle disease, and there may be restriction of eye movements also, but that is also going to be quite symmetrical, right? So please write that down very carefully for muscle. Examples are ocular myopathy, myotonia dystrophica. Please have a look at a picture of patient with myotonia dystrophica. So you can't see the slide. Make a pair. Dinuka?
Mataram pair, sir.
Maru වෙනවා පේනවනේ.
Oh, sir.
Sharing, I don't know, other people apparently can see. Okay. Okay, good. So bilateral ptosis can be due to myopathy, myotonia dystrophica. Please have a look at a picture of myotonia dystrophica on Google. Just Google it and see. But another very, very important cause of bilateral ptosis, and this is frequently the diagnosis at the short case, is myasthenia gravis. Okay, myasthenia gravis, frequently the diagnosis. So the important thing about myasthenia when you see it for a short case is the disease is asymmetrical. That's quite common to see that, right? So myasthenia will have a bit of asymmetry in the ptosis, and also in the extraocular muscle movements, they will be asymmetrical. You won't find the exact same on the left and the right, right? So there will be asymmetrical weakness of the extraocular muscles also. And remember, you will obviously have to elicit fatigability. So if you have bilateral ptosis, make sure that you elicit fatigability. And we will make sure at the exam that it's quite obvious. Fatigability patient කෙනෙක්. So very important. So the hallmark feature of myasthenia is bilateral ptosis with fatigability. Okay, that's very important. So I would say if you get bilateral ptosis for a short case, it is probably myasthenia, but be ready to discuss the other differentials like myopathy also, where probably the diagnosis is myasthenia. If you don't look for fatigability, you will fail the short case. So make sure bilateral to check for fatigability. And again, get an SR or registrar to show you the proper way of looking for fatigability. Thanks, if he has not already taught you how to do that. Okay, fine. Now remember, bilateral ptosis can also be due to various other neuromuscular junction disorders, but you'll never see those things in the short case, like botulism and snake bite. Short case. Right. Okay. Then remember, bilateral ptosis can also be seen due to polyneuropathies involving the cranial nerves. Right. And the classical example of this is something called Miller-Fisher syndrome. It is a variant of Guillain-Barré. So it is a polyneuropathy that also affects the cranial nerves. So Guillain-Barré, the variant, which is Miller-Fisher. And remember, Miller-Fisher, has somebody asks you, because in a discussion, you can ask you these things. Other differentials of bilateral ptosis, Miller-Fisher syndrome, there's a triad of symptom signs, right? So they have bilateral ptosis, ophthalmoplegia. Okay, ophthalmoplegia again is eye movement abnormalities, right? Which is also symmetrical most of the time. Ataxia, okay, ataxia, and hyporeflexia. The limbs are not weak, but they are unsteady. Ataxia and hyporeflexia. So complete ptosis and ophthalmoplegia, ataxia, and hyporeflexia are the triad of features you see in Miller-Fisher syndrome. Miller-Fisher syndrome. So bilateral ptosis can be due to myopathy, myasthenia gravis, and other neuromuscular junction disorders. Polyneuropathies involving the cranial nerves like Miller-Fisher syndrome. Miller-Fisher syndrome. Another cause of bilateral ptosis can be brainstem, midbrain disease, but that's very rare and has a very specific collection of physical signs that you don't need to worry about too much because it's postgraduate. Right? So that is brain. It's not in this slide, but please write it down. Midbrain disease, where you can get bilateral ptosis and a very odd collection of physical signs which are not important at an undergraduate level. Right. So etika tamai, these are the cause of bilateral ptosis. Bilateral ptosis. Okay. Right. So myopathy, myasthenia gravis, and polyneuropathies like Miller-Fisher syndrome and brainstem disease is the rare but last one. Okay. Just give me a minute. Right. Okay. Right. Any questions? So in this patient, I would think the most likely diagnosis here, you have to check for fatigability, but it will probably be myasthenia. Right? Probably be myasthenia. And then, of course, we can ask you some other questions for specific physical sign. Obviously, it's a fatigability. Bedside test in myasthenia is obviously you do the single breath count because you need to get an idea about the vital capacity. And then how you confirm the diagnosis is theory. So I think obviously Professor Chang would have taught you this. He does excellent lectures on these things in your neurology module. So he would have told you about the ice pack test and also obviously antibodies. Remember, the antibodies are not positive in everybody, and using the various antibody positivities, you can subtype myasthenia also. And I'm sure he would have gone through this with you, and I'm not going to talk about that again. Please revise your lectures. Okay, but for a short case point of view, clinically, this is the approach to a patient with ptosis. First, ask yourself the question: is it unilateral or bilateral? And then, if it's bilateral, then work on could it be a myopathy, myasthenia, Miller-Fisher, hemophilia. You would work up. All right. Okay. Any questions from that case before we move on to the next one?
Excuse me, sir.
Yes, Chamat.
සර් මේ asymmetrical තියෙනකොට එක අර වැඩිපුර ටෝසිස් තියෙන හැ අරින්න හදනකොට අනිත් හැ වැයෙන මොකක් හරි එහෙම ටෙස්ට් එකක් තියෙනවා.
Okay, අපි අතින් අරින්න හදනකොට.
ඔව්.
නෑ එහෙම ගන්නෑ. එහෙම ගන්නෑ. As far as I know. Yes. Okay, fine, good. Right. So have a look at these pictures, and obviously the diagnosis is obvious. So you can see ptosis is almost complete, right? Almost complete. And this is the patient looking to the right. Okay, B is the patient looking to the right, and C is looking to the left. So you can see that the lateral rectus is working, but the medial rectus is not. So just by looking at these three pictures, remember the exam, you'll examine more eye movements, but just looking at these three pictures, you can decide that this patient has a left-sided third cranial nerve palsy. So let's talk about that then. Third cranial nerve palsy is a very common short case, very, very common. All right. And I've just given in the text here that there is pupillary involvement, but we'll come back to that in a little while at the end. Right. So when you have a third nerve palsy, again, just diagnosing the third nerve palsy is not going to give you full marks. You need to diagnose the third nerve palsy and explain why you say so. So in a third nerve palsy, you'll have ptosis and involvement of all the extraocular muscles except the lateral rectus and the superior oblique. Okay, lateral rectus and the superior oblique. And then you need to diagnose it, but not only diagnose it, you should also be able to describe the location of the problem. Okay, location of the problem exactly. Now, this small sort of table, it's slides, but it's better if you understand here, write it down in the words that you can understand also. Right? A short case make a table. So when you have a third nerve palsy, you need to say where along the third nerve the lesion is. So there are several points that you need to consider here. Right? So the third nerve palsy could be due to a problem in the midbrain. Okay, could be a problem in the midbrain, right, involving the third nerve nucleus. So if it is a problem in the midbrain involving the third nerve nucleus, remember that there will be additional physical signs. because other structures close by to the third nerve nucleus also will be affected, right? Because all of this is vascular, most of these are vascular, right? So remember that the corticospinal tract will be affected, and that gives rise to a contralateral hemiparesis. Why is it contralateral? Because the pathway hasn't crossed to the proper side yet. It crosses lower down in the medulla, if you might remember that. So you get a contralateral hemiparesis, right? And also you can get cerebellar signs, but remember cerebellar is all, remember there are connections between the midbrain and the cerebellum through the cerebellar peduncles. And these also affected when there is a lesion around the third nerve nucleus. So you'll get ipsilateral cerebellar signs. So remember that. Why is it ipsilateral and the weakness contralateral? Again, if you remember your neuroanatomy, they would have taught you there, cerebellum always is connected to the same side. Crossing එකක් නැහැ. Cerebellum, the cerebellar hemisphere are on the same side. That's what they control. So the part of the cerebellum that controls the left side of the body is the left side. So it's not confused. So it's ipsilateral always. So if there's a third nerve lesion in the midbrain, then lamai, you will have a contralateral hemiparesis and ipsilateral cerebellar signs. And also remember, near the third nerve, there is this big structure called the red nucleus, and you can get a tremor when the red nucleus is affected. Not very common. So don't worry if you can't remember that, but you will get a sort of a tremor when you have that red nucleus being involved. Right. Okay. And I've given you some causes of midbrain disease there. Okay. So most important thing then, if the third nerve nucleus is due to a midbrain lesion, you will expect the patient to have contralateral hemiparesis and or ipsilateral cerebellar signs. Right? So that is important to remember. So keep your eyes open because so පොඩ්ඩක් ඔය පේනවා hemiparesis එක එහෙම examine කරනකොට පේනවා. Right? Otherwise you will miss it. Right? If you are not careful. Some people check for pronated rift after the third nerve. They find a third nerve palsy, which is also a good thing to do. So if you find a third nerve palsy, actively check for pronated rift. Remember, a pronated rift can අත් දෙක කොහොම එළියට තියාගන්න කියලා බලන එක. That can detect a hemiparesis. Okay, so please make a note of that. Right. The next thing you know is that when the third nerve exits the midbrain, it lies very close to the posterior communicating artery. Very close to the posterior communicating artery when it exits the midbrain. So an aneurysm in the posterior communicating artery can cause a third nerve palsy. And remember, it will be an isolated third nerve palsy that you will see. Isolated third nerve palsy. Hari. ඊට පස්සේ මොකද වෙන්නේ? Now remember your neuroanatomy මේක හොඳටම දැනගන්න. Third nerve එකේ pathway එක අනිවාර්යෙන් දැනගන්න ඕන එකක්. Then what happens is the third nerve enters the cavernous sinus. Cavernous sinus. Now within the cavernous sinus lamai, you have the third nerve. Okay. Cavernous sinus එක කියන්නේ මොකද නහය දෙපැත්තේ තියෙන එක, right? So නහය කියන්නේ it's deep, but obviously it's in the midline. So in the cavernous sinus, there are other cranial nerves which are in close association with the third nerve, right? What are these? You have the third nerve, fourth nerve, sixth nerve, and the ophthalmic and maxillary divisions of the fifth nerve. So the ophthalmic and maxillary divisions of the fifth nerve. So if there is a cavernous sinus lesion, you will have all these cranial nerves being involved. And a common etiology of cavernous sinus lesion would be cavernous sinus thrombosis. So if there is cavernous sinus thrombosis, expect to find 3, 4, 6 and ophthalmic and maxillary divisions of the trigeminal nerve being involved. Expect to find that. So in addition, if there is cavernous sinus thrombosis, we will also see that pintura, eye being red, proptosis, ඒ වගේ දේවල් පේන්න පුළුවන්. Right. Okay. Right. So midbrain, important. Remember these patterns. This is very important for your short case. When the third nerve exits the brainstem, it enters the, it lies very close to the posterior communicating artery. So therefore, you will have an isolated third nerve if there is a posterior communicating artery aneurysm. Then going into the cavernous sinus, you would have 3, 4, and 6, and 5, 1, and 2 being involved, right? And that the common etiology is thrombosis, and you will find other signs as well. Okay. Right. එතන පොඩ්ඩක් යටින් ලියා ගන්න cavernous sinus thrombosis කියපු තැන the cavernous sinuses on either side they actually communicate in the midline. So it's not unusual in cavernous sinus thrombosis to find bilateral signs also. But එහා පැත්තෙත් පොඩ්ඩක් තියෙන්න පුළුවන් ප්‍රශ්නේ. Right? So you can have bilateral signs because the cavernous sinuses communicate in the midline. So එක පොඩ්ඩක් note එකක් විදිහට එතන ලියා ගන්න that you might find bilateral signs කියලා. Because there is communication between the cavernous sinuses. Left and right cavernous sinuses. Right, okay. Then beyond the cavernous sinus lamai, the third nerve enters the superior orbital fissure, which is a hole in which it enters the orbit. So in the superior orbital fissure, you have 3, 5, 3, 4, 6 and the ophthalmic division of the trigeminal nerve. 3, 4, 6 and ophthalmic division of the trigeminal nerve. Right? But the maxillary division is no longer there. It's left already. Sorry. The maxillary division is already left. It's just the ophthalmic division that you have now. Okay. Then මෙතන මේ table එකේ නැති තව තැනක් තියෙනවා ඒක ලියා ගන්න. So following the superior orbital fissure, the third nerve is in the orbital apex. So the orbital apex is the starting point of the orbit. So as it leaves this hole, it is in the orbital apex. Now in the orbital apex, 3, 4, 6 are together. But the trigeminal nerve has now left. There is no trigeminal nerve in close relation. 3, 4, 6 විතරයි තියෙන්නේ. But obviously the optic nerve will be in close relation. Right. දැන් ඔය තැන් තුනයි බලන්න. So if it's a cavernous sinus lesion, 3, 4, 6, 5 ophthalmic division, maxillary division will be involved. If it's superior orbital fissure, 3, 4, 6 and just the ophthalmic division will be involved. Tuna, if it's the orbital apex, 3, 4, 6, but there will be no trigeminal nerve involvement. Additionally, you might, however, get optic nerve, say visual acuity loss, right? You might get that. Okay, right. So third nerve in the midbrain we have talked about, precom we have talked about. Then we have talked about cavernous sinus, superior orbital fissure, orbital apex. And then also remember, you can have an isolated lesion of the third nerve also along its pathway. That's called a mononeuropathy. Mononeuropathy of the third nerve. So mononeuropathy of the third nerve is things like diabetes that cause mononeuropathy. So that's an isolated disease along the course of the third nerve. Doesn't involve anything else. It's just the third nerve. Mononeuropathy. Right. So ask any questions if from this table. So there's an additional column that needs to come in, that is orbital apex. Any questions?
So excuse me, sir.
Yes.
In the third nerve nucleus in the midbrain, you have mentioned bilateral ptosis.
Yes. So so this actually I've put this table you make a postgraduate table. So just forget about that for the moment. Don't worry about that. You can get bilateral ptosis, but the physical signs are slightly different. It doesn't cause a complete third nerve palsy in one area of the midbrain. Okay. So there are various areas. Actually, there are about 5 different midbrain syndromes. The one that causes a full third nerve palsy will be associated either with red nucleus signs or contralateral hemiparesis or ipsilateral cerebellar signs. Where you get bilateral ptosis and other things are due to a different part in the midbrain. Okay, is that fine? Don't worry about that. Again, don't worry about it. But if you find a third nerve palsy, clear third nerve palsy, it is in a different part of the midbrain. It is either associated with contralateral hemiparesis or ipsilateral cerebellar signs or red nucleus signs. Okay.
Excuse me, sir, for the orbital apex involvement, it's only the third, fourth, and the sixth nerve, right?
And the optic nerve.
Okay, thank you.
Okay, right. So let's go back to the case number 3, where we have a patient with a third nerve palsy, and this is isolated third nerve palsy. Okay. Now, if you look at this table, there are only 2 causes of isolated third nerve palsy. Actually, 3. What are the 3? So isolated third nerve palsy can be due to a midbrain tweak. But remember, if it can be easily excluded by looking for hemiparesis, right? So, but if you don't look for hemiparesis, you might mistake that it's isolated, and be careful with that. So it's always a good practice after you finish the cranial nerve examination. If you find an isolated third nerve palsy, just ask the examiner, can I look for pronated drift to see if there's any hemiparesis? We know, all right, this guy knows what he's doing here. Because you're looking at that for a particular reason. So isolated third nerve can be due to midbrain disease. It can be due to a PCOM aneurysm, or it can be due to diabetic mononeuropathy. Right. So imagine this patient now, there is no hemiparesis. Now you're left with 2 options. What are the 2 options? Either it's a PCOM aneurysm or it is a diabetic mononeuropathy. So how do you resolve that to 1? Narrow that down to 1. Easy. You look at the pupil. Okay? So again, there's a little bit of neuroanatomy that you need to remember here. If you take the third nerve, the pupillary fibers are going on the outermost aspect of the third nerve, pupillary fibers. These are the fibers that cause constriction of the pupil. So these are the fibers that cause constriction of the pupil. Any compressive lesion, right, of the third nerve will cause pupillary dilatation, because the pupillary fibers, they are the first to be affected. Okay, so that will cause dilatation of the pupil. But diabetes does not cause pupillary involvement, because the disease starts actually more in the middle of the nerve, more centrally. So just by looking at the pupil size, you can say whether it's a PCOM aneurysm or a mononeuropathy. Right. So let me discuss that again. With this case, third nerve palsy, 3 possibilities. Isolated third nerve palsy, 3 possibilities. What are the 3 possibilities? Midbrain lesion around the corticospinal tract, midbrain sort of red nucleus area, or it can be a PCOM aneurysm, or it can be a diabetic mononeuropathy. If you look for pronated drift and exclude that, the midbrain story goes out of the window. You can exclude that. Then the other 2 you can differentiate by pupil. If the pupil is dilated, it is a PCOM, because that's a compressive lesion and involves the outermost pupillary fibers. Diabetes does not cause pupillary involvement. Okay, that is how you differentiate. Any questions from case number 3 then? So in this patient, there is pupillary dilatation, so we can conclude that is probably a PCOM aneurysm, right? And obviously you need to do an angiogram in that sort of patient. Any questions? Please ask if you have any questions.
So excuse me, sir.
Yes.
I forgot to ask this, sir. If the patient is having Horner syndrome,
Yes.
again, do we need to do we need to say it is either in the brainstem or somewhere in the neck
Oh, so
area?
that's a little, you can do that, Prasant, you can. So what we know, Prasant, if there's a Horner syndrome, do we need to localize it? You can do that, but it's extremely difficult to do. Okay, so you can say, is it in the brainstem or the hypothalamus or where it is, but it's very difficult to do. At your level, if you get a Horner syndrome, the 2 things you need to look out for, number 1 are lateral medullary syndrome. Okay, and that's not very common, but it's a possibility. The other one is Pancoast syndrome. But the kind of Pancoast is when you have an apical lung tumor that can appear in short case. So those 2 look out for, but it's actually possible to say exactly where it is. Whether it's a sympathetic problem in the hypothalamus or where it is, but that's a very difficult examination. It involves looking for sweating in various places and certain special things that we don't routinely do. Right? Okay, fine. So case number 4 then. Okay, case number 4. So case number 4 is again ptosis. Right? Now, even though the right side looks like there's ptosis, take that as normal. So right side also looks like ptosis, but don't worry about that. Assume that's normal. So say the disease in the left side. So there's complete ptosis, but the eyeball is not moving anywhere. So So this is the neutral position, left, right. This eye is moving, but this is not. Left eyeball is not moving anywhere. Hari? Okay, fine, good. Right. So now you need to think of where the localization is. So left side complete of the eyeball is not moving anywhere and sensory loss in the ophthalmic division. Okay. So complete ophthalmoplegia means there is 3, 4, 6. 3, 4, 6. Okay. 3, 4, 6. So now go back to this table. Based on this localization, we know that 3, 4, 6, all of the 3 nerves can be affected in 3 places. What are the 3 places? It could be in the cavernous sinus. It could be in the superior orbital fissure. It could be in the orbital apex. And I just now told you that if it's in the cavernous sinus, you will have 3, 4, 6 trigeminal first and second divisions. If it's in the orbital fissure, it will be 3, 4, 6 trigeminal ophthalmic division. If it is in the orbital apex, the trigeminal nerve will be normal and you might get a bit of optic nerve disease, which is loss of visual acuity, right? So that is how you work that out. So in this case, then where is the lesion? I have mentioned here in the text that there is sensory loss in the ophthalmic division of the trigeminal nerve. This is a what? Cavernous sinus, orbital apex, or superior orbital fissure? It is a superior orbital fissure lesion. So it's 3, 4, 6 and ophthalmic division, right? Okay. So orbital, so it's in the superior orbital fissure. Could be superior orbital fissure. Okay, and there is a granulomatous disease that affects the superior orbital fissure called Tolosa-Hunt syndrome. Read about that. Tolosa-Hunt syndrome. So Tolosa-Hunt. Tolosa-Hunt syndrome. Okay. So now you know how to work out various types of third nerve palsies, right? Any questions from third nerve palsies? So this is, so you can see the MRI, there is a lesion in this patient. The arrow shows the lesion, right? And this is a superior orbital fissure lesion. In an orbital apex lesion, the trigeminal nerve would be normal. And in a cavernous sinus lesion, the maxillary division would also be affected, right? The cavernous sinus is somewhere here, okay? A mouse pointer can pen in a hurry. So mouse pointer can pen in a hurry. Okay, fine. Okay, any questions from third nerve palsies? Right. Then make that come put out, but essentially, as good at the Nisa. But essentially, the problem is, as you can see in this image, right? That is a right-sided lateral rectus palsy. So this is representing a right-sided lateral rectus palsy. So let's talk about the 6th nerve now. And also the fundus, if you look at the fundus, it shows papilledema. I will come back to this sign. Right, so again, localization. Where is the lesion? Where is the lesion? Now, similarly, like the 3rd nerve, the 6th nerve, you need to know the course. But it's easy because if you know the 3rd nerve, you can work out the 6th nerve. Right. So 6th nerve starts in the pons. Okay, starts in the pons. And again, in this region where the 6th nerve nucleus is, right, the motor pathways or the corticospinal tracts are in very close relationship. So if there is a pontine lesion causing a 6th nerve pulse, you will have a contralateral hemiparesis. Okay. In addition, what's not mentioned in this table is close to the 6th nerve nucleus is also the 7th nerve nucleus. Very, very close. Very, very close to the 6th nerve nucleus is the 7th nerve nucleus. Okay. So if there is a pontine lesion causing a sixth nerve palsy, you should also expect to find a lower motor neuron or a nuclear seventh nerve palsy on the same side. So that's a very good sign. So if it's a brainstem lesion or a pontine lesion, you expect to find sixth nerve palsy, seventh nerve palsy, and contralateral hemiparesis. Okay. Okay. And similarly, you will have ipsilateral cerebellar signs because the pons and the cerebellum are very closely connected as well. Ipsilateral cerebellar signs. Harine. So that is if the lesion is in the pons. Okay. And forget about this conjugated gaze palsy. Okay. Fine. Now, when the sixth nerve exits from the pons, it has a very long intracranial course. Very long intracranial course. Okay. And increased intracranial pressure can cause compression of the sixth nerve, right? That is, you know that. Right. Now, the next important landmark in the course of the sixth nerve is it passes close to the apex of the petrous temporal bone. Apex of the petrous temporal bone. So it passes very close to the apex of the petrous temporal bone. And in that point, at that point, the sixth nerve is closely related to the fifth nerve. So sometimes this is not a very common problem, but when you have inflammation of the apex of the petrous temporal bone, you can have sixth and fifth nerve palsy. Sixth and fifth nerve palsy. Sometimes you get this following an ear infection, inner ear, middle ear infection. There is inflammation of the apex of the petrous temporal bone. So that is 6 and 5. So 6th nerve in the pons will be 6, 7 contralateral hemiparesis, ipsilateral cerebellar, long intracranial course. So increased intracranial pressure can cause an isolated 6th nerve palsy. Then 6 and 5 can lie very close to one another near the petrous temporal bone. Right. Then from this point onwards, cavernous sinus, same 3, 4, 6, 5, 1 and 2. Superior orbital fissure, same 3, 4, 6, 5 and 1 go close together. And orbital apex is a new thing that you learned today. 3, 4, 6 and just the optic nerve close together. Okay. And also finally remember the 6th cranial nerve, like the 3rd cranial nerve, can be affected along its whole course as a mononeuropathy. Right? Example, things like diabetes. Okay. So that is essentially the pathway and the localization of a 6th nerve palsy. So, yes. Question? Is there a question? Right. So pons, petrous temporal bone apex, cavernous sinus, superior orbital fissure, orbital apex, and mononeuropathy. Those are the places. Right. Any questions from that approach? So it's all pattern recognition, right? All pattern recognition. Fine. Now, if you go back to this patient, this is an isolated 6th nerve palsy. Now think, what could cause an isolated 6th nerve palsy? Only 2 things, no lamai. One, it could be diabetes, causing a mononeuropathy of the 6th nerve, or it might be increased intracranial pressure with a compression of the 6th nerve. Okay. So how do you differentiate the two? Very easy. Look at the fundus. Right? Fundus එක පේන්නේ නැති එක වෙනම කතන්දරයක්. But papilledema තියෙනවා නම් you know it's increased ICP. Right? And once we gave this actually a patient with a 6th nerve palsy and papilledema. And that's a common case. You can find these patients very easily. Right? And only, of course, maybe from about 20 people that got the case, only 1 person asked to look at the fundus. Fundus එක අහපු එකටම we know, right? You know, this person knows what they're doing. And also actually that candidate detected papilledema also, which is excellent. And that person got full marks. CNCM දුන්නයි. No doubt, right? Of course, other people didn't fail, but that candidate, without even prompting, asked for the ophthalmoscope to look at the fundus and detected papilledema and told that the etiology was increased intracranial pressure. So full marks, right? That is how these short cases work, right? So isolated sixth nerve palsy then is due to only two causes, either diabetes or ICP. Diabetes එක තව එක vasculitis එහෙමත් වෙන්න පුළුවන්, but diabetes තමයි common thing. And looking at the fundus will help you to differentiate, right? That very nicely. Any questions? Any questions from that part of it? Okay. Good. Perfect. Right. Now let's move on then to this patient who has an interesting problem, but clearly a seventh nerve palsy. You can see that the angle of the mouth is deviated to the right side, right? And you can see a prominent nasolabial fold on the right. Right? And also you can maybe see that there is absent or minimal wrinkling of the forehead on the left side. So using this case number 6, we'll discuss facial nerve palsy. Now, facial nerve palsy, when you have a patient with a facial nerve palsy, the first thing to do is decide, is it an upper motor neuron or a lower motor neuron facial nerve palsy? That is the first thing to do. So in your sort of head, when you're trying to localize the problem, do that first. Differentiate upper motor neuron from lower motor neuron. And this is something that you're quite familiar with. In a lower motor neuron type facial nerve palsy, the whole face will be affected. But in an upper motor neuron type facial nerve palsy, only the lower part of the face is affected. There is a difference. And right from your first year or second year, when we first taught you neuroanatomy, we have been explaining the reason for this. And that is because the upper part of the upper motor neurons, right, supplying the upper part of the face, have a bilateral cortical innervation. So if you take the facial nerve nucleus, the upper part of the face, the facial nerve nucleus, has bilateral upper motor neuron innervation. That is why you get this difference. So if it's upper motor neuron facial, then easy, it's a stroke, so don't need to worry about that. But let us focus on lower motor neuron. Like this patient has a lower motor neuron. The whole face is affected. As you can see, there is minimal wrinkling on the left side also. Right? Obviously, the exam, you'll be not looking at a picture. You'll be eliciting these signs and it will be far more clearer and obvious. Right? So lower motor neuron facial. So like we have done the third and the sixth lemma, it's very easy to use a similar approach here as well. So if you follow the course or the pathway of the seventh nerve, you'll be able to sort of make this localization very easily. Right? And you already know brainstem, seventh nerve lesion in the brainstem, you already know because we discussed that with the sixth nerve. So if there is a facial nerve problem in the midbrain, you will have a lower motor neuron facial, sixth nerve, contralateral hemiparesis, and also ipsilateral cerebellar signs. That is quite obvious. So we already know that. If your lower motor neuron facial nerve palsy is not in the brainstem, then there can be some other places also. Right. So after the seventh nerve exits the brainstem, right, which is the pons to be more specific, it enters the cerebellopontine angle. The cerebellopontine angle, CP angle. Cerebellopontine angle. Now, in the cerebellopontine angle, right, which is the gap between the sort of, it's in the sort of fossa or furrow between the pons and the cerebellum. The cerebellopontine angle also has other cranial nerves within that, which are in close proximity to the seventh nerve. So what are these cranial nerves, Lamai? We have the 8th cranial nerve and the 5th cranial. So these are in very close proximity, 7th and 5th. Remember the 6th nerve, and write this down very, very prominently, Taruaddala. The 6th nerve does not enter the 6th nerve does not enter the CP angle. That goes anteriorly. The 7th nerve goes laterally and enters the CP angle, and within the CP angle, as I have described, you have 5, 7, and 8 close together. Right. So if you have a patient with a CP angle problem, they will have 5, 7, and 8. And remember, problems in the CP angle are often due to tumors, and they also have cerebellar problems, right? Because it presses on the cerebellum also. So that's a very nice diagnosis to make, and we do give these patients for the exam because we can find patients with CP angle tumors from neurosurgery, right? And even when you're practicing for the exam, it is a good idea to go to neurosurgery wards and see if you can find these patients, right? So 7, 5, and 8 together, maybe with cerebellar signs, would be CP angle. CP angle. Then what happens is the seventh nerve now enters the internal acoustic meatus, right? In the internal acoustic meatus, the nerve is related to the 8th cranial nerve. 7 and 8 are together. And then 7 and 8 travel together inside the petrous temporal bone also, right? So if there is a problem in the petrous temporal bone, say for example, if you have a middle ear infection, which is a severe infection spreading into the bone also, you get a 7th and 8th nerve lesion. ඔතන මේ other features කියන තැනට පොඩි theoretical point එකක් දාලා තියෙනවා here. Inside the petrous temporal bone, the 7th nerve actually gives off 2 branches, right? What are the 2 branches? One, chorda tympani, which gives taste in the anterior 2/3 of the tongue, and also something called the nerve to stapedius, right? Which sort of dampens the sound that we hear, right? අපිට ඇහෙන සද්ද පොඩක් අඩු කරලා දෙන්නේ මොකද නැත්නම් සද්ද වැඩි. So dampens, right? So you can actually, using the function of those 2 branches, localize where exactly in the petrous temporal bone the lesion is කියලා කියන්න පුළුවන්. හරි? But at an undergraduate level, ඒක එච්චරම අපි අහන්නේ නැහැ, but you should know that inside the petrous temporal bone, chorda tympani is given off, and also this nerve to stapedius. So by examining the function, the taste function, and when the nerve to stapedius is gone, it causes hyperacusis. So using those signs, you can actually determine හරියටම කොතනද කියලා කියන්න පුළුවන්. Inside the petrous temporal bone, where exactly the problem is also you can localize, but that is mostly postgraduate. Theory එක දැනගන්න ඕනේ, but exam එකේ ඒවා කරන්නේ නැහැ අපි. Right. Okay. Then the 7th nerve, again still inside this petrous temporal bone, forms another important structure which is called the geniculate ganglion. Geniculate ganglion. Now you can have an isolated lesion of the geniculate ganglion, and this is a famous problem which is called Ramsay-Hunt syndrome, which is an isolated lesion of the geniculate ganglion due to herpes zoster, right? So that can cause an isolated 7th nerve palsy, but also herpes zoster vesicles cunning, right, in the auricle. Right, in the auricle or the external acoustic meatus එක හරිය you get the vesicles. So there is a special thing which causes isolated 7th nerve palsy and due to herpes zoster. That's called Ramsay-Hunt syndrome. Right. So just to recap, then the 7th nerve starts in the brainstem in the pons, right, and then travels. So you know that the lesion in the pons, what the physical signs are, travels into the CP angle. So 5, 7, and 8 nerve lesions, cerebellar signs would be CP angle. And then 7 and 8 go into the internal acoustic meatus. And then you have these branches inside. And then geniculate ganglion lesion, Ramsay-Hunt syndrome, is isolated 7th nerve palsy with vesicles in the external acoustic meatus. And then the 7th nerve exits the stylomastoid foramen. Again, inflammation in the stylomastoid foramen causes isolated 7th nerve palsy. Right? This is called Bell's palsy also. That's inflammation of the stylomastoid foramen, commonly after a viral infection, right? And then finally, the 7th nerve enters the parotid gland and branches off into various branches within the parotid gland. Right. Okay, right. So that is the cause and the localization of a slower motor neuron type 7th nerve palsy. Then පොඩ්ඩක් අපි හිතුවොත් එහෙම, of these places, what can cause an isolated 7th nerve lower motor neuron type palsy? Isolated. ඒක විතරයි ගිහිල්ලා තියෙන්නේ. හිතන්න බලන්න. So if you start from outside, yes, a parotid gland tumor, usually a malignant tumor of the parotid gland, can cause an isolated 7th nerve palsy. So the message there is, if you have an isolated 7th nerve, look for parotid masses, scars and things very carefully. Right. Then a lesion in the stylomastoid foramen like Bell's palsy can cause an isolated seventh nerve palsy. Okay, right. Then also a lesion in the geniculate ganglion can also cause an isolated seventh nerve palsy. ඔය තුන තමයි එතකොට එන්නේ isolated. Because from that point onwards, petrous temporal bone, CP angle, brainstem, there will be other cranial nerves that will be affected. So the three causes of an isolated seventh nerve palsy would be parotid tumors, stylomastoid foramen inflammation of Bell's palsy, and Ramsay-Hunt syndrome. Any questions from this course and localization of this lower motor neuron 7? Upper motor neuron එක very easy. Stroke no එක ගැන හිතන්න දෙයක් නැහැ. Lower motor neuron එක තමයි පොඩ්ඩක් කල්පනා කරන්න ඕනේ සමහර වෙලාවට. So coming back to this, yes.
Sir, may our greater petrosal nerve එක මේ ඇතුළත දෙන්නේ
AY lesions අමාරුයි localize කරගන්න. Yes, it also give the two important branches are ටික තමයි.
Okay.
Now in this patient, you can see the lower motor neuron facial, and can you see the vesicles in the auricle sort of external acoustic meatus there? In B, figure B, you can see the vesicles. So this is a classical case of Ramsay-Hunt syndrome. Okay, so patient has Ramsay-Hunt syndrome, and the lesion is in the geniculate ganglion. Okay, so another case of seventh nerve palsy. And here you can very clearly see the lower motor neuron 7th. හොඳටම පේනවා. Eye is not closing properly. Eyeball මේකට මේ S බෝලේ කළු ඉංගිරියා උඩ යන එකට it going up is called Bell's phenomenon කියලා කියනවා. සමහර එක මේක උඩ යන්නේ නැහැ. එතකොට the cornea is exposed to infection and damage. Right? This is called Bell's phenomenon when the cornea goes up and gets hidden under the eyelid. So you see that, and you can see a obvious deviation of the mouth and a prominent nasolabial fold on the right side. So there's a left-sided lower motor neuron facial nerve palsy. And from the case, it says in the text I have given, sensory loss in the trigeminal nerve territory and impaired hearing on the left ear. So from a little localization table, now we know the lesion is where in the CP angle. Lesions in the CP angle because 8 and 5 are affected. There may or may not be cerebellar signs depending on the size of the tumor because the CP angle lesions are often due to acoustic neuromas, right? And depending on the size of the tumor, there can be cerebellar signs also. Right. And here you see the tumor, right? මෙතන මේ ඊතලයක් කහපාට ඊතලයේ තියෙන tumor there. Okay. Here. And the cerebellopontine angle is here. මෙන්න මෙතන තියෙන. Right. Any questions from that case number 7, I think, yeah?
Excuse me, sir.
Yes.
Sir, then partial ptosis තියෙන patient කෙනෙක් දුන්නොත් sir අපිට motor cranial nerves examine කරන්න කියලා අපි මේ eye movements එහෙම sir check කරන්නේ කොහොමද bilaterally හරියට?
ඒතර හැරලා බලන්න ඕනේ සමත්. So that's important. If ever you have ptosis, you have to open the eye with your hand and examine the eye movements. Right? Another challenging thing is to check their visual fields also. Now remember, if there is squint එකක් තියෙනවා, ඒ කියන්නේ resting position එකේ squint එකක් තියෙනවා, you can't examine the visual fields because එක හැක් එක පැත්තකටනේ තියෙන්නේ, so all the visual fields are distorted. But if they have ptosis, you still have to, and there's a particular way of doing that. ඒකත් අහන්න කාගෙන් හරි කාටරි පෙන්නන්න කියන්න කරන විදිය. Right? If there's ptosis, you have to either you can ask the patient to lift the eyelid and do it, or there is another way of doing it also. So ඒක අහගන්න කාගෙන් හරි technique එක. So you to ask somebody show you how to do a visual field examination in a patient with ptosis, and also how to do the eye movement examination in a patient with ptosis. ඒක eye movement එක බලන එක නම් ඇහැ උස්සලා බලන්න ඕනේ නැත්තම් වැරදිනේ, පේන්නේ නැහැනේ. ඒවා ඉතින් technical දේවල්, මට දැන් මෙහි ඉඳන් පෙන්නන්න අමාරු දේවල්. හරි?
Thank you, sir.
In case number 7, does she have some kind of a ptosis? So, why is that? This patient.
Ptosis තමයි ඇස් වහලානේ තියෙන්නේ. May have වැහෙන්නේ. It's not ptosis. So this is actively closing the eye. Ptosis is the resting position. So here you're asking them to actively close the eye. That is different from ptosis.
Sir, අරකින් CP angle එක චුට්ටක් ආයෙ පෙන්නන්න පුළුවන්ද මේ
Method. CP angle is here. So this is the pons, this is the cerebellum. CP angle කියන එක මෙතන තියෙනවා. There. So this tumor is there and extending into the cerebellum. Probably might be even arising from cerebellum, not sure. Right. Okay. Okay. Now the last case, I think, maybe last one. Yeah, one last two cases are focusing mostly on sort of lower cranial nerve palsies. Lower cranial nerve palsies. Right. So here you can see there is tongue wasting. And if this was a video, you will obviously also see fasciculations also, but this is not a video and you can't comment on fasciculations here. Right. Now, and I've given in the text that there are fasciculations and also bilateral palatal movements are impaired. Now, when you see lower cranial nerve palsies, you should see if the signs fit into a bulbar or pseudobulbar palsy. Right? So when you ever have lower cranial, tongue එකේ ප්‍රශ්න, palate එකේ ප්‍රශ්න අරක මේක තියෙනවා නම්, especially if the signs are bilateral, but එහෙම වෙන්න ඕනේ නැහැ, you need to see if they fit into a bulbar or pseudobulbar palsy. That is the first thing that you need to do. Now, yeah. So bulbar pseudobulbar palsy refers to lesions of the medullary cranial nerves or cranial nerves in the medulla, which are 9, 10, 11 and 12. Okay, 9, 10, 11 and 12. Especially 9, 10 and 12. Also remember, part of the fifth nerve is also in the medulla. Okay, part of the fifth nerve, that is the motor part of the fifth nerve, is in the medulla. Motor part. Right? Motor part. Medulla. Because the third nerve nucleus is a big nucleus, which is split up into different parts. There's a mesencephalic nucleus, sensory, motor. Motor nucleus is in the medulla. So, upper motor neuron lesions of these medullary nuclei. What are the 9, 10, 11, 12 and trigeminal motor nucleus. Upper motor neuron lesion of these nuclei are referred to as pseudobulbar palsy. Pseudobulbar palsy. Pseudobulbar palsy. So there are a set of physical signs in pseudobulbar palsy. So, for example, their voice will be high-pitched. They have a small spastic tongue. So, spastic tongue tongue එක weakness එකකට වැඩිය, they can't really move the tongue quickly. So, la 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 කියලා කියන්න බෑ. If you ask it to put their tongue out and move it rapidly from left to right, they can't do that. So, very sort of spastic tongue එකක් ඒගොල්ලන්ට තියෙනවා. Right? Spastic tongue. So, they have a more nasal voice, small spastic tongue. Again, the palate is also නිකන් අර දැන් all spastic limbs දැකලා තියෙනවනේ. Weakness එකකට වැඩිය නිකන් ඒක නිකන් ටක් ගාලා යන්නේ නැහැ එහෙම. Spastic. And also their jaw jerk, which is innervated by the motor nucleus of the trigeminal nerve, is brisk. Right? So if you have these signs with a sort of lower cranial nerve problem, that is a pseudobulbar palsy. And this is a problem of the upper motor neurons. Might be stroke, demyelination, upper motor neuron lesion. Compared to that, if you have a lower motor neuron lesion, you will have all the lower motor neuron signs. So clear weakness, wasting, fasciculations, right, of the palate, tongue. Those are things that constitute a bulbar palsy. Bulbar palsy. So pseudobulbar palsy is upper motor neuron lesion. Bulbar palsy is a lower motor neuron lesion of the medullary cranial nerves. Medullary or bulbar cranial nerves, which are 9, 10, 11, 12 and motor part of 5. Any questions between that? So, when you start revising, practicing for the exam, neurology and neurosurgery, you will find these patients. Okay. Ask the SRs there, they will definitely show you and make sure that you cover these things and see these patients. Exam okay. Now here, in this case, it's clear that the patient has a bulbar type palsy, bulbar palsy. And bulbar palsy can be due to various things. They can be due to a problem in the brain stem. Okay, brain stem. There can be a problem in the base of the skull. Base of the skull kiyanne, because all these cranial nerves exit the skull near the base. So when there is a problem in the base of the skull, you can get bulbar palsies. Right? Base of the skull lesions are commonly seen in basal meningitis like TB, right? Or cancer, especially nasopharyngeal cancers which infiltrate around the base of the skull also. So lower motor neuron type sort of bulbar palsy can be seen in brainstem. It's uncommon, but exam you can see due to base of the skull lesions, nasopharyngeal cancer. Bulbar palsy can also occur, as you might imagine, because of neuromuscular junction problems like myasthenia. And also another common thing is motor neuron disease. Especially when you see a lot of fasciculations, it might be motor neuron disease. The exam make you discuss karantin. If you find a bulbar palsy, you will say lesion could be in the brainstem, but that's uncommon. But you will specifically think of base of the skull lesions or motor neuron disease. So mainly especially in this patient with a lot of fasciculations, you will say probably motor neuron disease. So I have told you in anterior horn cell disease or motor neuron disease, these fasciculations are quite obvious and common here. Any questions from that case?
So the stroke Georgia unilateral lesion risk
මොනවගේ stroke එකද කියන්නේ?
Cancer, pseudobulbar palsy.
Oh, yes. But ළමයි මේක හරිය මම මේක stroke එක හරියටම කොතනද කියන එක අනුව වෙනස් වෙනවා ඕක ටිකක්. But you can get pseudobulbar palsy in a stroke. ඒක possible. හරි? But පොඩ්ඩක් එහෙම වෙනවා තැන හරියටම අනුව. හරි? Okay?
Okay.
Excuse me, sir.
Yes, Mubin.
So if the command is to examine the lower cranial
Yes.
nerve and we
Yes.
want to examine the fifth nerve, but what do we do it at the end or do we ask?
Oh, okay, do it at the end. Ask. So, ඔක්කොම බලන්නේ නැහැ අපි Georgia එක විතරයිනේ බලන්න ඕනේ. Right? Georgia and maybe motor. So, ඒක අන්තිමටම කරන්න. That's okay. Ask the examiner, can I examine this? And when you ask, we know that you are doing it for a reason, we know. Yeah. And that will obviously give you more marks. Don't do anything without asking. So don't say if they ask you to do the lower cranial nerves, don't do the fifth nerve without asking. So the examiner සමහරට තදදමික් කරන්න කියපු කරන්න වෙනේව බල සමහර අය ඕක කරනවා. Cardiovascular examine කරන්න කියනකොට it's common that you examine the lung bases for crackles, no? But it's better to ask the examiner, I finish the cardiovascular system, can I examine the lung bases for crackles? How would I come up?
Okay, sir.
Okay. Right. Now the last case for today, case number 9, is here you can see that the tongue is deviating to the left. Tongue is deviating to the left. So remember, so there is a hypoglossal lesion on the left side, right? So remember the tongue deviates to the side of the lesion. Tongue deviates to the side of the lesion. So this is a left-sided hypoglossal nerve palsy. Now, also given in the text that when you examine this patient, there is a left side hypoglossal palsy. Also, there is wasting of the left sternocleidomastoid and a left palatal palsy. So this is more of a bulbar palsy category. It's a special type of lesion. So don't call it a bulbar palsy. It is a special type of lesion where you can exactly say where the problem is. හිතලා බලන්නකො කොහෙද කියලා bulbar palsy කියලා shape වෙන්නේ නැතුව මේක හරියටම localize කරන්න පුළුවන්. So where is the lesion exactly? So there is a left-sided hypoglossal palsy, palatal palsy, and wasting of the left sternocleidomastoid. Very focal problem, ne? So කොයි හරියද lesion එක ඇත්තේ? මේ figure එක බලුවම ඔයගොල්ලන්ට තේරෙයි හරියටම තැන කියන්න පුළුවන්. So there are two holes that you need to remember at the base of the skull, which can sometimes give rise to very specific lesions. One, here is the jugular foramen. So my laser point is on the jugular foramen, which is 9, 10, and 11 jugular foramen. And then here is the hypoglossal canal, which is the jugular foramen එක යටින් තියෙන hypoglossal canal වෙන මෙතන. ඔය ඊතරේ ගහලා තියෙන මෙතන hypoglossal canal. Okay, hypoglossal canal. So it's actually separate. So there are some tumors that affect only the jugular foramen. Okay, tumors can press on the jugular foramen. So if it's a pure jugular foramen lesion, what would be the physical signs? Just 9, 10 and 11, not 12. But when the tumor becomes larger and larger, it can also press on the hypoglossal nerve, right? So, and cause something like what this case number 9 describes, 9, 10, 11 and 12 on one side, very focal on one side. So here this lesion is at the base of the skull and probably involving the jugular foramen and the hypoglossal canal. So pressing on those two parts. Sometimes it's not uncommon to get a pure jugular foramen lesion where it's 9, 10 and 11. එකපාරක ඔය විභාගෙදී කවුරුත් කිව්වේ නෑ ඕක. හරි කවුරුත් කිව්වේ නෑ ඔක්කොලම එක නාගත්ත හොඳටම. It's a rare thing, but again you might find these patients in neurosurgery. So they'll have just a palatal palsy and a sternocleidomastoid weakness, 9, 10 and 11. That's a pure jugular foramen tumor. Okay, so those are little bit, those are two sort of cases of lower cranial nerve palsies. Right? Okay. Fine. So that is it. So here you find the tumor. It's quite a big tumor involving the jugular foramen and the hypoglossal canal at the base of the skull. So this is the base of the skull. It's actually extending below the base of the skull also, or slightly below. Okay. Hi. Any questions? So today we have covered all the cranial nerves, and this class is extremely important, as you might have realized, because මේවා තමයි විභාගෙට දෙන්නේ. Right? So I have completely covered the cranial nerve short case. Now you need to see patients and also you need to perfect your examination technique. Specifically the ones I told, how to check for fatigability, how to check the visual fields if there's ptosis, how to check the eye movements, if there, those sort of technical things you should perfect now. Yeah. Right.
So when we are examining, is it better to ask for fundus examination while doing the second examination? Or
Yes, it's better. It's better. So now, for example, now if you say motor cranial nerves, you're not going to examine the fundus. No? So if you find a sixth nerve, then you will ask the examiner, can I look at the fundus? But if they say upper cranial nerves, you will ask to examine the fundus. Ne? So it depends on what command. So it's always better to ask. And examiner no need unless there is something interesting to find, right? And we'll just tick a box saying that you know that the fundus has to be examined. We just tick a box.
Sir, when they ask to do the lower cranial nerves, we directly start. We go ahead and directly start from 7.
Yes.
So in that case, if we later need to, if we later need to do any other upper cranial nerves, we just ask, or we.
So if you have lower cranial nerves, balala, Hari. Then you ask if you want to check any other upper ones. You ask the examiner.
Okay.
Sir?
Yes.
Sir, facial nerve palsy එකේදී eyelid එක වහන්න බැරි වෙන්නේ if it is supplied by the third nerve and the sympathetic component.
Third nerve එකෙන් කන්නේ ඇහැ අරින එකනේ. So opening the eyelid, closing the eyelid is by the orbicularis oculi. So orbicularis oculi is 7th.
Okay.
Yeah.
I thought
opening the eyelid tamai levator palpebral superioris.
Okay.
Closing is orbicularis oculi, which is 7th.
Okay, thank you.
හරි. හරි. දිනුක හරිද එහෙනම්?
හරි සර්.
Sarangani, the next MCQ class is next week, right?
So that's 23rd, not this weekend.
Hari. I'll put the rest of the questions. Yeah.
And the slides for the last.
Oh yeah. Ekad danna. Yes. Hari. Okay. Right. Hari, I will see you on Monday then.
Okay sir. Thank you.
Okay. Right. Bye.
Thank you sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.